so welcome. I wanted to, first of all, acknowledge that I'm sitting here on the Colville Reservation in North Central Washington. All of us today, as long as you're sitting here in our region, you are sitting on the historical lands of the Confederated Tribes of the Colville Reservation. So I welcome them as our partners. I'll ask everyone to look on pages 4 through 14 while we go over the roll call. I want everyone to also know that we'll be looking at the approval for the consent agenda. At this time, I would like you to say that you're here if you hear your name. So Carlene Anders, here. I'm looking here. Kathy.
Here.
Thank you. Deb Murphy. Sorry, you.
Here.
Thank you. Del Anderson.
Here.
There you are. Jesus Hernandez.
Present.
Ken Sterner.
Here.
Ramona Hicks. Ray Eichmeyer.
Here.
Rebecca Davenport.
Here.
Thank you. Rosalinda Kibbe. Senator Warnick.
I'm present.
Yes, you are. Hello. Dr. Tuckey.
I'm here.
Thank you. Pat Littett. I think she was going to be absent. Teresa Atkinson. Nancy Spurgeon.
I'm here.
Thank you. And just to go back through Carlene Anders, have you joined us yet? Ramona Hicks. Teresa Atkinson. All right. We'll go ahead and thank you, John, for pulling up. First, welcome, John, that you're still here. No baby means you're here, so that's some news. The consent agenda this month, we will be starting to add in the monthly financial report again. So in the last few months, it has been sent separately. So it will be contained within the consent agenda. And at this time, I offer and welcome any motion to approve.
I'll make a motion that we approve the minutes as read and presented.
Thank you, Deb. Do I have a second on that?
Second.
This is Ken. I'll second that.
Okay. Any discussion, questions? He pulls up the financials. All right. Hearing none, all those in favor, say aye.
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 Opposed would be nay. Abstained? No. Motion carried. Thank you for approving that consent agenda. If you are a guest present, if you could go ahead and put your name and organization in the chat. I also offer any public comments at this time if anyone has anything that they would like to add prior to starting our meeting. I will also give you a chance at the end during our roundtable if you need to say something. Also, does anyone have a declaration of conflict? Any of our board members today? If so, would you please let us know? If during the meeting something comes up that you believe could be a conflict of interest, please let us know. You can put it into the chat or raise your hand and we will acknowledge that for you. Otherwise, I think I will pass this on to John for the acting executive director update.
Good afternoon, everyone. Thank you all for bearing with us on some of the technical difficulties at the start. Just to note, Molly had said that I may not have been here, and I thought for a while this morning I was not going to make the board meeting this afternoon because my wife was due last week, but I am here and hopefully I will be out later on tomorrow or the next day. But I will keep board members informed, of course. So just really going through some key updates for statewide. As you guys all know, the MTP renewal is coming up and the application is planned to be submitted middle of July. The Healthcare Authority has moved its public comment period. It was originally supposed to run from mid-April to mid-May, and they pushed it back about a month to run May 12th to June 13th. Michael Arness from the Healthcare Authority will be joining us today to present a little bit more in-depth detail on the waiver renewal. Last meeting in April, we covered basically the highlights of what the Healthcare Authority is proposing. And this time, he'll spend a little bit more in-depth detail on specifically the accountable communities of health role and some additional detail on what they're looking at for health-related services and for care coordination. What I really would encourage everyone when you listen to the presentation today is to hear what questions you may have, especially around the ACH's role and the waiver renewal, and any comments, anything that excites you, or any concerns you might have as well. We'll be working with the community in May to collect some feedback, but we are also planning on submitting a public comment on the behalf of North Central ACH. So any comments or feedback we hear today, we would love to include in that comment period, and we'll plan to share a draft with the board in May. The other statewide update is that the Healthcare Authority is working with CMS to come out and give a presentation on the alternative payment model for CHART, which is Community Health Access and Rural Transformation. And this is really a transformation alternative payment model for the public hospital districts, or predominantly focused on any hospital in a rural area. Just as a reminder, North Central the Healthcare Authority applied for the CHART grant with CMS to focus on the North Central area, and they formed an advisory committee that developed a transformation plan, and now really are taking a break until the payment model comes out and the hospitals in our region have an opportunity to look at the payment model and determine if they're interested in participating or not. So at the end of May, they will be coming out to present that draft version of the payment model, and then in July or in June, they should be having a version that's publicly posted. One thing we're going to try to do with updates for the executive director updates is really provide our updates as they're outlined based on the strategic goals that we approved this year. And so you can see again up on the screen the 5 strategic goals that we approved for the board back in December, and we'll run through really based on each of those strategic priorities, the work that's occurring underneath that. What I would continue to ask you all as board members is to let me know if this is helpful, if there's more ways that we could explain the information in a better format. What we're trying to do is utilize the executive director reports in a little bit more detail to keep the board up to speed on the work that's going on with the ACH, but also ensure that you understand how it ties back to some of the decisions you guys have made as board members as well. So specifically around the strategic priority of building a culture of equity and community resilience, We have engaged in a contract with Karen Francis McWhite to really help us build out how we're going to engage the board and engage the community in this priority. Our current focus has really been on looking at our board and our staff materials and looking at how we work to educate and build that culture of equity internally with us. One of our original priorities underneath this objective was to provide board education at least 4 times a year on health equity and equity in general. What we really are doing is we're tweaking that priority a little bit to really focus on board and staff, and really looking at how we build it into both our board and staff documents, HR processes, policies and personnel manuals, board handbook. And so Karen is going to be working with us to get that developed. And then when we have the board orientation packet and board application materials finalized, we'll share it with the board for review and feedback. What we are also looking at doing is providing a little bit more education and training at the July board retreat, so July 15th. So you will be seeing some of these discussions come into our board retreat in July. We also have been looking and discussing, re-looking at our equity statement that we presented early last year in 2021. And we will be bringing that back to the board as well. Any questions? And if you have questions, feel free to pop them into the chat while I go along, or feel free to just interrupt me and ask a question or make a comment. So another one of our priorities is cross-sector collaboration. And we really have 2 major initiatives that are coming up this next month. And so I'm going to actually ask Caroline to share some of the details, because you all should be hopefully seeing these come in your inboxes and track whether there's an assignment for you to do for the survey or to share with partners you think would be eligible for upcoming funding. So Caroline, can you share a little bit about the cross-sector collaboration funding and the network analysis survey?
Yeah, so I'll start with the network analysis survey, because that's the one that was actually released. It went live Monday of last week. And this is the survey we're doing with the help of Visible Network Labs. They joined us at the March partner convening to talk about social network analysis and how it can be used to build relationships and increase the strength of networks. Many of you probably got the survey link, but not all of you. So the way this works is there's a list of organizations that we think are part of this broad scope of health and well-being. And one person from each of those organizations receives a survey. And there's a series of questions about which organizations you partner with. And what's really great about social network analysis is it doesn't just help us see who's connected to whom, but how they're connected. And what I mean by that is that you get to see how many connections there are from one organization to another, and also how deep they go. So we will be able to understand and learn about measures of value and trust across our network. And with this map and this data, we'll be able to gain insights for improving community partnerships and strengthening connections that influence health and well-being. So it will be helpful not only to our work this year, but also to the work that we're envisioning in this future state of ours. If you have questions, I'm happy to take them right now. If you haven't seen the survey link, but you think maybe you should have, feel free to reach out to me. And I'll pause there just to see if there's any questions about that. Okay, so I will move to the cross-sector collaboration funding. This will actually be announced tomorrow. We wanted to make sure we brought it up to the board today. So this is part of the budget, the 22 budget that you all approved last year. And it's directly linked to the strategic priority that you see on this slide. Essentially, the funding is targeting cross-sector collaborations and integrated partnerships And what we mean by that is we're intending to support more intentional partnerships between organizations from different sectors. So it's really intended for 2 or more organizations from different sectors that would like to work together towards a shared purpose that improves whole person health or health equity. It could also, we would accept applications from single organizations that need to work on internal capacity and processes, as long as the organization can show how that internal work will allow them, will set them up for cross-sector collaboration. The application will kind of defines the intent a lot more. We're planning on accepting applications on a rolling basis, and we're planning on involving community partners in the review process. I think in some ways it's an extension of what we had tried and begun to put in place last year through the community-based care coordination funding, and it's taken it one step further. And yeah, I'm excited to see what comes through. But we all know, and we've talked about from the very beginning, even in the Medicaid transformation, that cross-sector work and work outside of the healthcare sector is really important. And we all think, we've talked a lot about social determinants of health. So this is a way to invest in community solutions that drive at that. So I'm excited to see what comes through. We'll make sure we update you just the way that we'll update you about the rest of the funding proposal, like the telehealth. You know, Wendy will talk about that today. Like, how do we plan on keeping you posted so that you can help us adjust if we need to? We will do the same with this funding. We'll keep you posted and we'll make adjustments if you feel we need to. So I'm happy to take any questions right now about that funding. Otherwise, look out for the announcement, which should go out tomorrow.
This is Molly. Oh, my goodness. And I work for Rural Resources, and I believe that we are in a collaboration with Cooley Medical Center. So I just wanted to acknowledge that. I'm not part of any of the discussions or anything. I'm a worker bee on that. So,
yeah, and Molly, that work is actually a perfect example of the types of partnerships we would hope to see more of. Rural Resources and Cooley Medical actually began working on this last year through the TCDI funds, I believe, right, John? And also through some of our community-based care coordination funds. So that's what I mean, like this kind of investment it's really building on things that we've been testing out in the last year. And yeah, but it's a different pot, Molly. Any questions from board members on this? Okay, John, I think I'll give it back to you.
Perfect. The only other thing I would mention on the slide is upcoming May 17th is our monthly partner convening, and we're going to focus on the vital conditions and community engagement involvement in this work. And what I would probably call out for board members, I know you've seen the vital conditions and some presentations on it in the past. This is a framework we've looked at adopting, and we've had a number of discussions on at the NCACH level. So if you feel like you have some questions around that in this work, I would actually encourage you to listen into that session to learn more about how we are looking at community engagement and vital conditions work. It would be very informative, and I think would help kind of engage us and move us along in some of these conversations at the board level. Under the behavioral health section, I really just want to call out a lot of the work that is going on with the recovery coach work. And so Grant County Jail has started their pilot program. And I believe, Joey, you can confirm, have they started seeing jail patients already or jail residents?
Yeah, they have.
Perfect. And we are working on getting a emergency department pilot going in conjunction with Hope Source and Samaritan. So those are two things in Grant County that are really getting up to speed and have a lot of energy and enthusiasm under it. I really have to say, I believe Samaritan has really jumped into this again with the ED work, and they've been really excited to see this come to fruition. Regarding Narcan vending machine, just a quick update to share is that Joey is meeting with Rural Resources in the Grand Coulee area, and they're looking at adding a Narcan vending machine up there. And really, the vending machines have been heavily utilized. And it is my understanding that about half of the doses that we expected to use in a year have already been utilized in the first 3 to 4 months. And so Joey's been really talking to Beacon to see what options are out there to continue to stock the machines and see if this is going to be a continual trend or not. And I wanted to ask Joey for a moment, just with a lot, you guys hear a lot every month about the recovery work going on. I just wanted him to share a little bit about some of the things he's hearing and the kind of impact that this work is really making in our region. So I'm going to turn it over to Joey quickly.
Thanks, John. So on the recovery coach work, we started in Chelan County first, and there's a gentleman that we're working with who has had a history of substance use for most of his life, and he was somebody that reached out and asked for a recovery coach in Chelan County Jail. We started working with him. He got released after about 6 months, and so in that time we were visiting him once a week, and the day he got out, we picked him up from jail, and we already had his treatment plan figured out, and he went right into the Center for Alcohol and Drug, completed their treatment plan. We started working with him while he was in there, and that man has housing now, a good job that he's been at for a few months, and is very active in the recovery community, and also is going to be one of our future recovery coaches. And I always share that with this population, like, you guys are the future of this work. And once you give them that passion of changing their negative lived experience to something positive for helping people, you see a light bulb and a light turn on in their head. It's been an honor to be able to do this work. I'm really passionate about it. And the Narcan vending machines, another awesome tidbit is we've given out right around 550 doses, and that's just with 2 machines. Since then, this doesn't count Okanagan County or potentially Rural Resources, but we've had 34 overdose reversals. Because we've been doing data collection for a few months, and those 34 overdose reversals, only 2 of them was 911 called or EMS, or were they put into the hospital, which shows like how many of our overdoses are undocumented that just slip by. And without this vending machine, that would have been 34 deaths, because these people don't feel comfortable accessing Narcan at a pharmacy or anywhere else in the community, and so this is their only source. So yeah, that's it for updates for me. Anybody
This
have
is
any
Molly. I also just wanted to acknowledge that as Rural Resources, the need when I started this office in November was so great. I just had to stop and think about how many touch points can I make in the shortest amount of time. And the Narcan vending machine was always something that I knew that we needed with the number of deaths we have in this community. So thank you. I wanted to acknowledge that.
Anybody have any questions? All right, thank you.
So on the policy side, one of our objectives was really to coordinate and streamline how we work with the payers. And I got to give Wendy a lot of credit. She has been working with Kat from CHPW to get a MCO meeting together quarterly and really focus on some of the objectives that we can work together on and collaborate on together across the state and even with our local partners. And so we are going to be getting those scheduled here moving forward pretty soon. I know I saw Wendy send another follow-up email to Kat to get those objectives finalized and on the calendar. And we will also be connecting with Beacon as well in the regular cadence to do a similar kind of meeting so that we can really look at how we can leverage and work with the MCOs together to move this work along as a region. A lot of times this regional initiative stuff really does, and I will call out, I don't know if there's any MCOs on the call today, but again, they're a very vital partner in this work and they can make a lot of difference. And we really want to make sure that we're doing things in alignment with them and figure out where we can collaborate and where some areas where we may have disagreement. And then statewide, a lot of the focus has been on the waiver renewal, and you'll see, again, a lot of that come through with Michael's presentation. Specifically on capacity building, we kicked off a quality improvement sprint a couple of weeks ago, and the quality improvement sprint is focused on how to do quality improvement with community-based organizations. Mariah's taken the lead on this, and I really want to give her a shout out for getting this organized. And really, it's taken a lot of the lessons learned from the Whole Person Care Collaborative quality improvement work that Wendy got established and looking at how those concepts can be utilized in community-based organizations as well. Quality improvement, PDSA cycles can be applicable in a number of areas, and it's useful to get both clinical and community organizations up to speed on that. Other than that, also just a call out in trainings is that we have another 25 recovery coaches trained this last quarter. And so Joey, do you know what the total of our recovery coaches trained is?
132. And about 35 to 40 of them are employed and embedded in healthcare setting, community-based organizations, and or local treatment centers.
So again, that's just an example where we've developed some capacity building and some training locally to get people ready to move into employment opportunities. And we did not create every one of those employment opportunities. A lot of those came with the movement of recovery coaching, and individuals in our area were just well positioned to move into those roles because of that training. And then finally, some staff updates. I want to welcome Sarah Bates, our Director of Community Data. I can see her waving on the left side of my screen. Sarah joined 1 week ago today, or 2 weeks ago today. I can't remember, 2. And she's really jumped right into it, really spent time focusing on the role of the ACH and really jumping into how she's going to be really focusing on bringing our region together to anchor and shared measurement, our second pillar. And it's been great to have her aboard. I see you unmuting, Sarah, so would you like to say a word or two?
Just an accident, but hi, and I look forward to getting to know the board much better. Yeah, I'm glad to be back home in the Wenatchee Valley. So thank you.
And then another staff update, June 1st, Morgan Eastman will start as our communications manager. As you guys know, David Gaynor, our previous communication manager, had left to take a position in the Spokane area. And we had a very competitive process in our first application pool. And since it had only been a few months since that transition, we went back to our previous application pool, analyzed the candidates, and connected with Morgan and interviewed her. And she will be starting June 1st. So we are really excited to get that position up and running as well. Some quick board updates. We will be developing, I said this earlier, but developing equity training for the board in July and reviewing the equity statement. I just call that out again because I had a few board members in our conversations acknowledge or recognize that we're not always 100% clear on how all of us see equity or how we see its work or how NCACH works with equity in the work that we do. And so we're going to spend some time focused on that. And then we completed an initial draft of a board orientation packet and a board application. And when that gets done, we will also be sharing that with board members as well. And this was also something that was called out in some of the board conversations to help board members better understand their role, what the ACH does, and how we can really look at the kind of impact we're trying to measure. Other than that, any other question or any questions or comments for me or the team?
If you wanted to look at, just your East Wenatchee, this is the same as 1.0 where you can look at your different locations within the
I think, Rachel, you are not on mute. Thank you. I didn't think that was a question. If not, I will turn it back to you, Molly.
All right, thank you. And I think that feedback that I got meant that I could get onto the microphones, but I'll wait till our break on that. At this time, I would like to welcome Ken Sterner, who is head of our election committee, the board election committee. And go ahead, Ken, I'll leave it with you.
Right. Good morning. Thank you, Molly. Okay, well, we have received a nomination for our board. This nomination is on behalf of the Okanagan CHI representative. If many of you remember, Lisa Apple was there and resigned in October, and it's taken a while, but we finally have a great candidate. Peter, I started to go south on this. I was really going to give you a hard time today about your candidacy, but I thought that'd be nice. For those of you, most of us know Peter Morgan, first of all, when he began working with originally with the CHIs began, and I would bring in myself and Jesus and some of our older members who remember those days sitting around the health department and around the desk trying to go through stuff. And then Peter also joined us later on as part of our staff as well. And now he's been nominated to represent the CHI there from Okanagan as well. And I would encourage everybody to go to page 15 to take up Peter's bio, and you're going to see that he has more than enough, I would say, in terms of qualifications and wonderful attributes to say that we wholeheartedly and 100% on behalf of the nominating committee recommend Peter Morgan to come to this board as a representative of the CHI. Peter, do you have anything to say for yourself before we pronounce sentence?
Well, it depends how the election goes, but no, I'm really pleased to be back in the mix again, and really excited to be a part of this and catching up with all the work that's been done in the last couple of years. So anyway, just yeah, thank you for creating the space.
Great. So with that, I would go ahead and on behalf of the nominating committee, make a motion to accept Peter as the CHI representative for Okanagan, and I'm looking for a second.
This is Kathy, and I second that.
Kathy, thank you very much. Thank you, Ray. She beat you. So we have a first and a second. All in favor, signify by saying aye.
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 Ayes?
Aye.
Any abstentions? That being said, thank you very much. Welcome, Peter. Madam Chair, it's back to you. Thank you very much.
Thank you very much. And welcome, Peter. I'm so happy that you're back. Although I was always in touch with you during Okanagan CHI, but that's good. I'm glad you're here. All right, now at this time, we'll go ahead and invite Wendy to talk about her telehealth project. Wendy?
Are you there, Wendy?
I am now. All of a sudden, my Zoom decided to go crazy when I was sharing my screen, so I apologize for that. Just want to confirm you guys see the right screen.
Telehealth Capital Investment Fund.
Perfect. So here we are again. I just want to refresh from the April board meeting, the motion that was on the table that was approved, the $2 million that was earmarked, calling out that last part, which is the NCACH staff were to bring back more detail about the framework for distributing the funds for the board to review prior to distribution, and that's what we'll be talking about today. So as the staff and I met after the last board meeting, we really talked about the different telehealth funding principles, what had been in informal discussions and putting it into this more formal way for you guys. So our primary principle that we are really going at is that all investments must directly or indirectly benefit a community initiative as we are moving towards more social determinants of health and health equity, and away from that truly clinical focus. We want to make sure that we are keeping our eye on that ball as well. We want to ensure that we're driving towards cross-sector partnerships between our clinical and community partners. So there are the direct investments, which is going to go straight to those community of partners, and we'll talk about those investments in a little bit. And then the indirect investments, which are, we would say for those clinical partners, identifying those cross-sector partners in the community and what is it that they want to, in that end goal, how they'll tie into some type of community initiative. And so they're looking beyond their four walls and looking externally to the community that they serve. And secondly, we will consider both equality and equity, two very similar yet very different words, probably similar in sounding, but different in principle. Each organization will have equal opportunity to request funding. We'll continue to ask ourselves these questions that we've outlined on the slide as we roll out the funding, and we'll strive for balance, but we're only able to fund based on the willingness and readiness of the communities and organizations, meaning that, say for clinical funding, if it's open to all organizations and you have 5 people in 5 organizations in Okanagan County applying for the funds, but only 2 in Grant, we're making it available for Grant County, but if they're not willing to accept funding or build out their telehealth program through this funding, we can only do so much as staff. But we will make sure that we have reached out. Yes?
I think your Zoom is glitching because the slides have not advanced. So it still is on the title slide.
Oh, and I'm already on like
I know.
10.
I was
Just
thinking,
kidding.
I know she has slides about this.
1 second.
I just thought real long introduction, so.
Yeah, sorry about that. Let's see. Let me try this again.
And Wendy, let us know if you want one of us to try and share.
Okay. Do you see my screen now? Telehealth funding and principles at the top? No? Okay.
Now we do.
Yes, now. There must be a delay.
John, would you go ahead and share the slides? Just
Yeah.
the Zoom just glitched out on me.
I'm going to bring it up. Give me 1 second. And do you want to review any slides or just go right here? Did we lose Wendy? Oh, Wendy, you're a mute. We can't hear you.
Mute. How did I get muted? Strange. Okay.
All right, is this the correct slide?
It is. Will you just show them the motion real quick for those who, you have it in your packet, but I just want to make sure that you're familiar with the motion that was approved at the last meeting for those who were not with us. And let's go ahead and go to the next slide. And this is where I'm at right now. We talked about the direct and indirect, and now we're talking about equality and equity. We plan to follow the principle of equity when considering the fund distribution. Organizations will receive funds based on the need versus allocating equal amounts to every organization. So we will be assessing that through the funding process and distribution. And the staff will vet the funding proposals and the measurable outcomes before we distribute any of those funds. And we'll continue to ask those questions that are on the slides as we are receiving funding proposals and distributing those funds out. Next slide. It's also important that the entity receiving the funding has a physical presence in our region. We've recently seen entities outside our region receive funding to serve patients or clients in our region. However, there is little to know about whom that funding is actually going to help. This was recently seen with a recent funding, and it was for rural navigators, and all the individuals who received the funding were on the west side, but they apparently served individuals on the east side. And so we have yet to identify who they're truly serving and how they're tying into our telehealth, but we'll continue researching that. Because we really want to focus on cross-sector partnerships, we'll ask the clinical partners who receive funding to identify a community initiative they will tie into once they optimize their system. And this funding will be distributed over 2.5 years to ensure that the organizations who aren't ready have that opportunity to build in their telehealth system when they are ready. And finally, community initiatives will be individualized for each community. We want to make sure that we're not working on, say, school telehealth in a community when we don't have a clinical system to support it. So as we are moving forward, you'll see in just a minute through different phases, making sure the clinical has been optimized to provide services in the community and starting to tie in that way. And when I say clinical, for those just to help define, that is physical health and behavioral health. So we'll be working with both of those partners in the community for ability and readiness. Next slide. So some of the community initiative examples that were identified through the assessments were the library telehealth sites. They received some funding, and so we hope to be in their early planning process to build out some of that within their 30 different sites, identifying, prioritizing based on their readiness and willingness also. Also looking at community resource centers and other community-specific locations, such as fire departments and churches. Also looking at digital navigators, building on the work of the North Central Washington Tech Alliance, school-based telehealth, employer-based telehealth, and home-based senior care, all of which were identified through the assessments. Next slide. So as I was talking about earlier, there are two phases, although they're not independent of each other. The investments will be focused on clinical partners first, because investment in the community settings are dependent on the clinical capacity to offer effective telehealth services. And the overarching long-term intent of this earmark is to build capacity for community initiatives. Clinical organizations partner with the community-based organizations. If we build out the community initiatives before the clinical systems have optimized their telehealth services, they would be building a bridge to nowhere, leading to disappointment and frustration. So as you can see, there are multiple pathways for patients to access their telehealth appointments. As I said, there's two phases. Although it's not that we're going to finish one phase and then start the other, it's going to be very dependent on the community. For example, we have one clinical organization who's moving into school-based telehealth as we speak. And so we want to be able to help them, help the schools on their end to make sure that they have what they need so that we can make sure that that's a successful partnership. We don't want to be funding one side of the bridge and not the other side of the bridge to build these partnerships. So I'm really looking at needs and opportunities to ensure that there is some viable partnerships and successful partnerships that are long lasting. And so now let's look at the funding breakdown on the next slide. So you did approve the $2 million over 2.5 years. So that's through 2024. 1.5 million for the clinical telehealth, which is about 71,000 per organization. There's 21 organizations. Last month I said 75,000. I miscalculated the number of clinical organizations. I mistakenly left out 2 clinical organizations that we have not worked with in the past, and I caught that error prior to this presentation. So it's about 71,000. However, we know that through the assessments, and I think I go into this again a little bit later, that not everyone is going to need the 71 based on Ingenuum's assessment. We had as when looking at budgeted, some organizations needed like 25,000, which is, and up to as much as 80 to 100,000, but most of them fell within the $30,000 to $50,000 range funding that they would need to optimize their system. And so when you look at that, this 1.5 million would actually benefit those organizations who want to jump in later in the game if they're not ready to jump in right now, but maybe in 2023 they're ready to move because they start to see the early adopters and the successes they're having. They're going to start to want to engage in this work, and that funding will be there for them. And secondly, is their community telehealth optimization, which is 500,000, and we'll kind of go into that on the next few slides on what those investment opportunities are. Next slide. So we'll start with the clinical telehealth. There are 21 potential organizations in our region, 5 behavioral health and 16 physical health. 11 organizations engaged in Ingenuum initially. 7 have already expressed interest by completing an optimization survey. And that survey basically said, what services do you feel like you need and when do you need them? So do you need them right now? Do you need them soon, like towards the end of 2022? Or early 2023 or later than that. So we kind of had an idea of when they were looking at using certain services. And those 7 are broken down, 3 in Okanagan, 2 in Grant, 2 in Chelan Douglas. Some of the investments will include infrastructure for the clinical partners. We're estimating about $1 million will go to that, whereas about 500,000 would go towards that technical assistance, or go straight to Ingenuum to provide the technical assistance to those clinical partners in the form of education, coaching, toolkit, strategy development, and outcome evaluations. And next slide. And this has been shown to you before, but just as a reminder, these are the types of the supports, kind of high level infrastructure supports and technical assistance supports that Ingenuum could be providing, or hardware updates that we could potentially provide funding for to assist organizations. Next slide. On the opposite end is the community telehealth optimization. So we're looking at community organizations currently working on telehealth initiatives. So that's your clinical partner, your schools and your growers who are currently working with clinical organizations. The libraries is another potential location I spoke about earlier. And then there's some community organizations who are willing to host telehealth, such as the fire department, community centers, economic development centers that we've discussed. And then there's organizations working on digital navigators. So these are some of the things that we are approaching initially, but we'll also be reaching out to individual communities to look at other opportunities. Some of the investment types we are looking at is the need for technology or making the space private for appointments. In addition, we want to be able to provide them with some technical assistance, just as we're providing that to the clinical organizations. One of the biggest things, I spoke with a physician from Confluence who is in telehealth specialty. And one of the things I was asking, what is your need, or what is it that you see on a community side that you need? And he said the biggest thing is for the community is to have that private space, to have vital sign capacity, and to develop their workflows. So it really is working with those organizations to make sure there's a private space and they have workflows of how patients would come in and leave and access the technology and assistance with that, the technical support from that end. So next slide. What are our next steps? We would move forward with the distribution of funds based on the principles outlined today. We'll start with engaging the clinical providers who completed the assessment, as well as the library system and the schools to assess the barriers and needs that they may have. These are some of the early partners that I've been discussing that have already started to engage. We'll work with the partners to develop a plan and outline the need, the budget, the deliverables, and the measurable outcomes. And then we'll promote and support successful community and clinical linkages through that. Next slide. In addition, we'll do some outreach to clinical organizations who have first completed the assessment, but not the follow-up implementation survey, or have expressed interest in completing the surveys but did not initiate, and then all other organizations. We'll continue to send reminders just to let clinical providers know that this opportunity is available to them. And community organizations, we'll start with those who participate in the WSU assessment or the focus groups, those who are currently engaged in the community work, and then look at other opportunities identified through the community, through community engagement. And next slide. So as we discussed last meeting, that the staff will update the board when appropriate regarding the progress of the telehealth work and how this fund is being distributed. We'll move forward with the distribution of funds based on the principles outlined during the board meeting pending your approval. And that's all I have.
At this time, are there any questions? Anyone want some clarification on this request? There are no major concerns by the board. I do ask that the board approve a motion to move forward with distribution of funds.
Sorry, I didn't speak up fast enough. This is Nancy.
All right, thank you.
I'm just kind of learning about this. So, but I'm wondering if there is any way that the college is involved in this process or it has shown any interest.
I have not spoken with the colleges, and I'll have to look on the WSU's list of who they spoke to at the college, but I would welcome and encourage engagement with them.
Okay, I'll just mention it to some folks, but I mean, I don't know because I'm not on campus all the time like I used to be, but anyway, I thought.
And Nancy, if you're willing, I'm sure if you do an e-introduction for Wendy, she'd be happy to spend some time diving deeper and providing all the details if you think there's a point of contact that would benefit from it.
Yeah, I'd have to do a little research, but I know because I've retired and so I'm not there anymore, but there was a clinic on campus. So I'm just wondering if this is something that might connect to that.
And
Wendy.
Sorry. This is Rachel Petro. I was just going to speak up in regard to the clinic on campus, Nancy. There is still a clinic. CDCH has not yet explored telehealth options at that facility, but we'd be happy to chat more about that for sure, because we are looking at telehealth for our other outlying clinics.
Okay.
Wendy, this is Jesus, and this the answers I'm looking for might be in the application process, so just punt to that. But is there a plan for gauging or measuring the impact of the reach of these investments?
That is in the works of being developed. Yes.
Okay, thanks.
Wendy, this is Judy Warnick, and you might have covered it, Wendy. My question just is more logistical, and maybe this is something you'll be working on. The library connections with the libraries. Will there be opportunity for people to have more of a private conversation if they are utilizing libraries for telehealth?
It's a great question, and it is something that when we have originally talked to them in our initial conversations and in their renovations is making sure there is a private space. So we've talked about different soundproof type rooms so that they can go in and have that private conversation. This is definitely something we would set up out in the open, but we would maintain patient privacy.
Thank you.
Wendy, this is Ken. Just out of curiosity, similar to the libraries, have you done any outreach at all to the senior centers across the region?
I have, the only outreach that was done to me versus me to them because of the WSU and through those who heard about the presentations to the board. I have been holding off on outreach to understand the board's direction, but they're on my list of potentials.
And Ken, I would make the same recommendation I did to Nancy as well. If you want Wendy to connect with people, that e-introduction would be valuable.
Sure, absolutely.
And I would actually invite anyone that was interested or has someone in mind to let Wendy know, as well as John, just so that we keep a record of and touch all points. So.
Kathy, I saw you on mute a while back ago. I don't know if you were trying to jump in.
Actually, Rachel responded, so I appreciate that. I was just going to talk about the clinic, so thank you, Rachel.
And I added my email to the chat if you don't already have it. It's pretty easy to remember, wendy@ncach.org.
This time I would entertain a motion to approve to go forward with the distribution of funds based on the principles outlined in today's meeting.
So moved.
Do I have a second? Thank you.
Second.
Thank you. Any other questions or further discussions before I call for a vote? Hearing none.
Molly, I'm just
Favor say aye. Oh, good. Okay, Jesus, go ahead. Thank you.
Molly, I was just going to say that I'm going to abstain because of a potential conflict of interest because I may be an applicant.
Thank you. Thank you, Jesus. All those in favor say aye.
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 Opposed would be nay. The records show that Jesus Hernandez abstained.
This is Ray. I'll also abstain.
Ray as well. Thank you. Any other abstentions? And hearing none, motion carried and approved. Thank you.
Thank you.
Wendy. Now the work starts. All right. We were a little bit ahead of schedule, and we're scheduled for a break. So this would be probably a good time to take a 5-minute break. I'm going to see if I can fix my microphone. And everyone, I invite you back at 2:06. I gave you all a couple of extra minutes, but I will start the meeting again at 2:08. Thank you, everyone. I hope you were able to take care of business. And at this time, it's the MTP waiver renewal deep dive. It's on pages 29 through 43 of your packet. And John, I'm going to go ahead and send this over to you. Thank you.
All right. Well, today I just want to welcome Michael Arness, who's the Deputy Policy Director from the Healthcare Authority here today. Michael, I'm going to read a quick little bio on him. Michael has developed innovative programs that increased access to health care, promoted quality, and saved money. He has worked on behalf of low-income families, workers, and small and large employers and communities throughout Washington State. He is currently the Deputy Policy Director at the Washington State Healthcare Authority. I get the pleasure of speaking to Michael weekly, if not every other week, if not multiple times a week, and he's always been great to work with and very collaborative, especially with the accountable communities of health. I'm just going to also share personally, I know he is an avid runner, and whether he wants people to know or not, he has run the Boston Marathon. So any human being who can do that and qualify for the Boston Marathon is just an impressive person in general. And so with that, I will turn it over to Michael. And Michael, I am going to be sharing my screen. So you just let me know when you want me to transition with slides. The other thing I will note before I turn it over, though, I said this, Michael, sorry, I said this at the start of the meeting. I want you to hear this too. Really, this is our opportunity to provide feedback as an ACH on especially how we involve with the Medicaid Transformation Project and the waiver renewal. And so really ask Michael questions, share things you're excited about, things that you have concerns about as board members, and it will help us craft, a public comment to the Healthcare Authority as well. And Michael will be more than willing, and I know he really wants to hear those things. So I will turn this over to Michael.
John, thank you very much. It is a real pleasure to be able to talk to the board again, and especially about the renewal of the Medicaid Transformation Project. And these are valuable sessions because we finally get to talk with people one-on-one or as a group about what we're doing and where we're heading. So I just appreciate the invitation very much. And I should probably clarify that, yes, I aged into qualifying for the Boston Marathon. If I could, we could go to the next slide and talk a little bit, it just kind of grounds us a bit on the timeline that we're in here. Up to this point, we've spent the last 12 months working with ACHs and managed care organizations and other groups talking about what we would want to have in a new 5-year waiver. And I think as most people know, we're finishing up the 6th year of the current waiver. Our federal partners, the Centers for Medicare and Medicaid Services, give us an opportunity to ask for another 5 years waiver. So we have that opportunity to present some transformative and innovative material, different ways that we'd like to run the Medicaid program for the state. And it's a bit of a challenge because we have to project so far in advance of what we would like to do. And so I think, but it's the opportunity that we get, and we definitely want to take that. So right now, if you look at the second green bullet from March to April there, we are definitely in the period here where we are coming up to the public comment period. That's actually the third green point there, April through May. And we will be wrapping up the application this week, hopefully getting a final draft together that can go forward for public comment. And that's an important step for us, and it doesn't really change the conversations that we have every Monday with John and his colleagues. I mean, those continue, but it does change somewhat that we make sure that we have a 30-day period where the entire public in Washington State can review the draft application we've come up with and give us comments, and we stop changing the draft and put it out there so that everyone can see the same thing for the same 30 days. We are still focused on submitting the application to CMS July 15th of this year. And of course, that then begins a process of negotiation with CMS. We will have plenty of discussion with CMS back and forth. We expect to be sharing a lot of that with John and his other executive directors and the ACHs as we go forward, because a lot of those questions are statewide questions and we can't answer those ourselves at Healthcare Authority. We need to continue to engage people and talk about solutions. So John, if we could go next, it's a little bit more on some of the aims that we have here. And one of the things that you'll see here is that we set up that we want to continue to do whole person care. The second point, we want to continue to work with communities. And the third is we want to be a transformative payer. And we want to have integrated health and equitable value-based care. And what you'll see in these points here is that the word equitable is in each and every one. And one of the areas that we did not succeed in the last 6 years is in reaching everybody in the community. In fact, we worked with the ACHs on some transformative delivery system changes and work with community-based organizations, and it really showed in results for chronic illness care. It showed a lot in the results for substance use disorder and the opioid epidemic, and the data trended in the right direction. But what also we saw is that consistently people of color were lagging behind in those results. Two groups in particular, Black individuals and American Indian Alaska Natives. And so we figured that we were proud of the work that we did, but we also know we didn't reach everybody. And so what you'll see when we talk about the renewal is that we have some specific programs so that we can try to make sure that we get to everybody this particular time in the communities. And if we go to the next one, we're going to have to talk about the goals of the renewal. And we want to talk, we've organized the document more in terms of goals. And so we've lumped common initiatives into the goals here. And I'm going to go through this fairly quickly because we want to talk mainly about the third area because that's where most of our work is with the ACHs. But we want to expand coverage and access to care, ensuring people get the care that they need. And we have 3 items there: continuous enrollment at age 6, reentry coverage for people who are incarcerated, expanding postpartum care coverage. All of those were either suggested or directed by the legislature. And so we will be responding to those. And then, of course, our work that we're doing with substance use disorder and mental health in facilities, known as IMDs, where we can continue to pay for that care, but do so with federal assistance. And then advancing whole person primary preventive care, we have primary and behavioral health care integration assessment. We did integrate for coverage. We'd like to assess how to integrate at the clinical level better now. And then with long-term services and supports, that's with our partners at DSHS, and they have come forward with several innovative policies for the renewal. So that brings us down to accelerating care delivery and payment innovation focused on the health-related social needs. So there's 2 big areas that we've worked with the ACHs on. And before I get into the 3 blue points down there, but health-related social needs, those are all of those services that we work with community-based organizations on to address social determinants of health. All those non-clinical services that we know improve the health of families and communities. These are things like transportation, food, all those items that the clinicians have told us for years, could you please provide this through the Medicaid program to individuals, because that is sometimes what they need more than anything else. And then another concept that we've worked months developing with the ACHs is what we're calling the second blue point, their community hub model. And I want to talk a little bit about that because we've used the term hub for about 6 years now, and we've actually used it in terms of talking about a particular form of a hub, which is sometimes the Pathways Hub. And we realize we're using the word community hub again, but we mean something entirely different this time around. We're not being specific about the type of community hub that we're looking for each of the ACHs to develop. But we still want to build out this community hub model. And so what we've done there is we want to build out that model so that we can support those health-related services like food and transportation, and then also support the equity investments that we were just talking about that the Healthcare Authority would like to develop jointly with the ACHs. So the first blue bullet there, community convening and capacity, we are going to need a workforce to do this, and most of that is from community health workers. And so we are also putting forward a presentation to our federal partners at CMS that they help us with that, affording that workforce. We also want some form of community convening, and capacity building through the ACHs to carry out the work that we need. And then finally, foundational community supports. And that's an area that supports housing and employment, 2 very important health-related services. So John, the next one, we go in a little bit deeper dive on number 3 here. And if we could go to the next bullet, this is where we're going to talk a little bit more about health-related services. So we deliver health-related services in a fashion today through managed care organizations with the Medicaid program. It's really done on an almost one-to-one basis, and authorization has to occur basically for one individual to do one kind of service. We're finding out that when we do it, it's effective, but we need a way to develop more of a framework, more of a conveyor belt to the community that we can identify the services that are most predominantly needed in the community and make sure that we deliver those at a much larger scale than we do today. And we're really copying what has happened down in California on doing this, where California put together a list of services and said, these are the services that we would like to develop, see delivered throughout the community. We would like to have it, in a sense, pre-authorized, recognize that these services need to be done continuously and not always asked just for one-to-one approval and then move out and do it. But there's a recognition that the service is something that is part of the Medicaid program and it's just delivered as a course of services performed on a daily basis. And the way that we would like to do this, and this gets into a little too much Medicaid terminology here, but it's called in lieu of services. And as I said, we do this today, but we do it on a one-to-one basis, and we do it through managed care organizations. And what we want to do is just enhance that program. And if we put forward a proposal to CMS, it will be in the form of saying, here is a list. We've identified all these services. We believe these should be delivered to communities on a continuous basis and not have to be discussed and approved on a one-to-one basis, and that they're recognized as part of the services that we perform, and they will perform them at a much more predominant level throughout the community. But we also need to put something together for the fee-for-service community, because not everybody receives their Medicaid services covered through managed care organizations. So we will do that as well. And so our idea is to do this with MCOs and develop a partnership between ACHs and MCOs and to perform those services through the coordination of a community hub, where there would be screening and referral, and the hub community network can be used, like I say, to develop those services at a much larger scale, and to have those services then coordinated. The other thing is we want to explore some strategies to work collaboratively and leverage the MCO and ACH strengths. We feel like we work with two very good partners, the MCOs and the accountable communities of health. They both have strengths in how they perform with the Medicaid program, and we can do a better job of leading a group that can develop a much better way of working together to support our customers and have a much better, as I say, predominant way of delivering health-related services throughout the community. And then it's also possible that we may not be able to deliver everything through the managed care system. And if that's the case, we will do that through 1115 authority, through the waiver authority, and have a way of funding those services as well. And of course, we will, explore some ways to deliver these services to the fee-for-service population as well. So if we could go to the next slide, I think we're going to talk a little bit more about this partnership. So we have, in a sense, what we have here is health-related services. And then at the top line there, we'd like to use the in lieu of services format. We also have the fee-for-service and waiver health-related services should we need to. And we will need to somewhat for fee-for-service, because not everyone receives their care through managed care. And as we negotiate with CMS, they may want us to have some of the health-related services done through waiver payments, and we'll just be open to that. And then the third row there, the foundational community supports, or FCS, is those services that we're already delivering in the waiver for supportive housing and supported employment. They just help people retain housing and help people gain work and retain work. And we want to continue those services as well, and then coordinate better with that program through the community hub. So the health-related services definitely receive support through ACH implementation of the community hub. The ACHs will lead that network development and capacity building across community organizations in alignment with the community hubs. And of course, then we want to test some ways to work with MCOs and ACHs to have that streamlined contracting and reporting ability. So again, we're looking for a tighter working relationship, a more partnership-oriented approach to how we run the Medicaid program, because managed care organizations are terrific at certain functions. We know ACHs have proven themselves in their ability to work with community. We just want to take advantage of both sets of organizations so that we can deliver these services at again, a much higher scale than we do today. On the next one, I think, John, if we could go past this one, we use this for certain audiences. It's really a regulatory framework we borrowed from California. I think it gets real deep. Thanks, John. So these are some of the health-related services menus that we would like to get set up in Washington State and negotiate this through our partners with federal CMS. As you can see there, these are all the kinds of things that address those social determinants of health. Again, all of those non-clinical ways that we stay healthy. And I have to say that, for years, doctors and other clinicians have simply said, please, if you could find a way to deliver these services to individuals, and especially in the Medicaid program, please do, because sometimes that is what somebody needs more than the services that I'm bringing, as my clinical expertise. So again, housing transition navigation services, jumping down several, you see rehabilitation programs, nursing facility transition programs to assisted living. Jumping all the way down to the final three there, you see asthma remediation. Sometimes a lot of that is just an investment in somebody's home that can improve the kind of care that somebody gets who has asthma, so we're not continually going back to the emergency room. And the investments can sometimes be so minimal and actually very inexpensive compared to a stay in the hospital or several trips to the emergency room, over a several month period. Medically tailored meals, especially for people with chronic illnesses, very important, and the health impacts are proven out. And again, it keeps somebody living with the condition and healthy, as opposed to, again, making trips to the emergency room. And then sobering centers, which we're going to change that name to stabilization centers. Again, people just need places to go where they can become stabilized. We don't need to rely on the justice system. We don't need to rely on emergency rooms as well. If we can have us pay for a service like this, again, that is much more appropriate to what somebody needs, is very cost effective, and to the alternatives that we're using today. On the right side there, we have some of the other services that we believe may not be available to us through the in lieu of services system. And we anticipate that we may have to negotiate these with our partners at the Centers for Medicare and Medicaid Services to talk a little bit about how we might pay for these with the waiver dollars. So those are just some of the things that we will put forward. You'll see that in the application when it's made available for public comment on May 12th. And then next we can go to the next slide, John. I think we're going to talk a little bit more about the health-related services principles. Again, we want to continue to work with ACHs to build out those community-based organization capacity and to take on new contracts and services. And we plan to have that capacity building funds in the waiver. We want to leverage community information exchange, CI infrastructure where it's been built, and make it more robust, and of course have a strategy that connects the community information exchange throughout the state. We also want to ensure that we have shared accountability for health-related services. And again, this is where healthcare authority needs to leverage the strengths of ACHs and MCOs and build a much tighter relationship between managed care and accountable communities of health. We'll always need to have clear measurement and evaluation strategies we'll have to try to minimize variation this time so that we can create some administrative and streamlined effectiveness with our providers, and so that so people are not burdened so much just to carry out these services. And of course, as much as possible, minimize the administrative complexities and have some strategies that we work out with managed care organizations and accountable communities of health to streamline the contracting and the payment process. And then next, John, I think we're going to get into the hub, with the health equity programs first, but on the health equity, we have, excuse me, John, I'm finally in the office now, so I'm seeing people I haven't seen in 3 years who are waving at me. But we have, what we'd want to do is we have regional equity investments. And again, what we would like to do is understand that we are not going to reach everybody in a community if we don't set up a simple system with structures and some sideboards to ACHs on how we would like to carry out some health equity programs. And we've talked about this in the application that's coming out. We hope it's just a simple form of leadership from the healthcare authority that reaches out to accountable communities of health to say, let's work together to develop programs. It may be as much as finding new ways to deliver health-related services, but in ways that reach everybody. And we don't feel like this is going to happen if we don't make a priority out of it and ensure that we make an attempt to reach everybody in the community. So we will have equity funding. It will be, again, delivered to ACHs. We'll work hand in glove with ACHs on how to develop those programs. And then that way invest in community-based approaches that improve the health equity of all of the Medicaid clients. And then on community-based care coordination, again, we would like to do this through the community hubs. These hubs would, be regional and managed by ACHs. There's already been some coordination with Department of Health on Care Connect Washington. We want to make sure that where that has happened, that we leverage the investments to date. We also know that there's some core regional infrastructure for communities on convening and capacity planning, whether ACH is working on a community hub at the moment. There's a lot of this kind of work that goes on that is that we want to take advantage of, where relationships with community-based organizations have already been put in place. And the third blue point down there is something that we'd really like to make a priority on with the community hubs, and that is providing certain populations of emphasis with even higher touch care coordination for those community-based services. And one of the populations that's really come forward is that reentry population from incarceration. And what we'd like to ensure is that we really help those people transition back into the community. There's a lot of evidence that there is the need for this. We are losing people sometimes within the first week or two of reentering, simply because we don't have the coordination through the Medicaid program just for an individual to get right back into the services that they need, especially someone with who's been having substance use disorder, opioid treatment that is needed. We want to continue those services and not lose touch with individuals. So that's one of the ideas that we've had. We want to make sure that the community hub is available to help with health-related services, but we also want to make sure that there is a care coordination for these reentry populations of emphasis, such as the reentry population, so that we have a better care coordination system. And then, of course, we have ACHs convening with system capacity and workforce developments. We'd like to have workforce training and development done through the hub, because we know that this takes people. We have to have a better and stronger workforce of community health workers to carry this out, and we'll be requesting that from the federal government as well. And then the capacity building. I think just no shock to everybody here, just requires time. We don't plan on launching these policies and programs in January of 2023. We want to use 2023 to invest in the development of the hub, to invest with community-based organizations to help them learn how to coordinate with the hub and have a more effective coordination of these services. And of course, we need some time to work with managed care organizations and accountable communities of health to develop a relationship that leverages both of these groups. So I think, John, in the next one, we're going to talk a little bit about the hub functions. And as I mentioned earlier, we want to make sure that the hub is there to engage with all the Medicaid enrollees. So we'd like to make sure that anybody can go to the hub. It should have many ports of entry to the hub where someone can be identified and screened for any health-related services we need. That's the minimum that we would like to see happen with the community hubs. But we also want to make sure that we establish the networks with community organizations, which most ACHs have done to a certain degree to date, that we have some kind of connection with the patients with these community organizations. And again, some would be high touch approach and develop a comprehensive community care plan and try to coordinate the coordinators because we have caseworkers on the clinical side as well as the non-clinical side. So this is where for certain populations of emphasis, we'd like to have that high touch care coordination. And as we work through that with, say, the reentry population, we'd like to identify additional populations that we could work through these high touch coordination efforts. And then we want to make sure that we have follow-up, that we do track the outcomes to ensure accountability. And then we have a few more functions on the next slide that, or the roles discussions. Again, what we see is that there are some expertise that we'd like to take advantage of, and we know that MCOs work well right now in delivering health-related services, and they do have community connections with people, but they are also very good at doing the payment and have community-based workforce. From the ACH side of this, we have a delegated community-oriented health-related services group. We'd like to see if there's some ways that ACHs can play a role in testing payment strategies, ways that would reduce barriers, create efficiencies, and of course, possibly even have some community hub payments for community partners as they carry out the services so that we reward those who perform the work. Again, care coordination, we still see MCOs as doing the clinical care coordination, and ACH is continuing to do that community-based care coordination that is so essential for making sure that we have, feedback loops. And we know that if we're referring somebody to a food bank, that they actually arrived and received something. And then again, we'll have to have some kind of community information exchange or CIE and data. And we're working on that at the Healthcare Authority side to try to bring forward that information technology undergirding that's going to be needed for community hubs, and make sure that that is developed and a CIE strategy is rolled out throughout the state to support the kind of community hub operations that we'd like to see. And then John, next, I think we talk a little bit more about just open up for some questions here, but usually when I get here, John, I'm just open to advice, comments, any clarifying questions if people have them, but we are still very much in the listening mode, even as we are wrapping up the application for the official public comment period. And of course, this discussion will go solidly through the end of the year. So happy to hear from people now and all the way through the end of December as we continue to develop the application and negotiate it with our partners at Centers for Medicare and Medicaid Services. So thanks, John. Thank you. Over to you, and glad to listen or comment.
Let me ask, while it is fresh in board members and community and staff members' minds, so I would open this up to anyone who wants to join. When you look at the questions that Michael has on the screen, and you think of North Central ACH's role into this, what things come to mind? What comments come to mind that you think that we are well positioned for, or what things do you think you'd have some concerns about?
This is Ray. You know, I feel like we've made a lot of really good striving and work, especially with healthcare during this transformation. I think we've gone and created a fantastic cultural change with this work, but I am still concerned about the sustainable infrastructure. As you know, COVID kind of threw a big bat at us too with that and showed all our weaknesses. But what I am concerned about most is having a coordinated platform to communicate with our community partners or community-based organizations to do care coordination, because you can't rely on just one sector to take care of the community. We all have to do it together. I know that it's been tried to be done in multiple states with, frankly, failure. And so between the health exchange and no real infrastructure to do care coordination, those two things really, to me, can only happen from the top. It's got to happen from the state. It will never work unless you guys build it and make everyone use it, for the lack of terminology. The other thing is I still have not seen policy change from the health authority. There is a lot of work that we've been doing that's been being paid for by this funding, and to be sustainable, the healthcare authority has to change. And I see very little movement. There's been a lot of practicing and trying to trial and error to try to figure this stuff out. But now it's time to change some of those policies. There is still not funding for community paramedicine. I could keep going on to lots of different other areas that we can work on, but where we meeting halfway, that's the other thing we need to know. So you need to add policy on there.
Okay. Yeah. Thank you, Ray. And let me make two comments on this, if I could. I agree with you on the coordinated platform, and it does have to come from the state. And we need to have a form of a community information exchange statewide strategy that brings everyone together with an agreement on how we're going to work together to roll this out. So the healthcare authority received some money to start looking into how to do a statewide community information exchange strategy. We received $1 million to do that and to work with a consultant. And unfortunately, it's not to put the platform into place, but to develop how we could do it, and then to come back to our state legislature and make the ultimate recommendation that here's how we would like to go about putting community information or exchange, or what you called a coordinated platform, in every community throughout the state. It'll take much more than the $1 million that we asked for. And we plan on developing that package this year and then bringing it forward again to the legislature next year. So this year, we actually tried to go forward with the legislature and request much more than $1 million. We requested $15 million to do two things for that coordinated platform. One is to actually select a vendor that could be used in communities throughout the state. And the other thing is to develop ways to link the systems and take advantage of the infrastructure and that has been put into place already for community information exchange. So I agree with you. That needs to come from the state, and then it needs to be done in a way that builds that coordinated platform at the same time that we're working with URACH to put forward and have that capacity building with the community-based organizations and figure out payment mechanisms with you and the managed care organizations. So we need to get that approval. We need to move forward on that. So I'll be keeping John and all of his colleagues informed as we go forward on that. But it's not there yet, and I agree with you. It needs to be there. On the policy change, I could probably listen a lot more about what it will take to, like you say, the community paramedicine. But let me just mention one decision we made that may help with sustainability, and that's the part about the in lieu of services. And I know it's Medicaid terminology and minutia in the middle of a presentation, but it's the reason we're going forward there is that we're already performing those services through the managed care organization, and in CMS's viewpoint, it's an accepted way to perform food and transportation for individuals. And so by doing a system that's already in place and building on it, we run a much better chance of sustaining those health-related services throughout the state. So we're trying to, every time we can tack on to something that's already working, it improves how we, improves our opportunity for sustainability. And so that's hopefully a policy decision that will pay off in the long run. In the short run, our goal is to, again, leverage what we know managed care organizations and ACHs do well, and make sure that we have a system that delivers those kinds of services that address those social determinants of health. So, Ray, thank you. Those good comments for me to keep in mind.
And Michael, could I ask a question as well? This is Mike Tuggy from Confluence Health.
Yes, please.
Yeah, so just to make sure I understand the definition of the MCOs, are the MCOs you're referring to are managed care plans like Molina and coordinated care, or are you talking about the healthcare delivery systems as well in that definition?
Oh, thanks, Mike. Yes, specifically, in our package to CMS, we're referring to the managed care organizations, Molina, Coordinated Care, AmeriGroup, Community Health Plan of Washington, and the fifth one that's escaping me right now. And so,
okay, because I guess my concern about care coordination or case management of complex cases is that I think the reason why there's been a lot of failure in that work that's trying to be managed by the MCOs is that the funds don't trickle down to the actual clinics that are delivering that care, or the health systems that have the case managers that are embedded at the clinics, because the effectiveness of that care is so much on the patient's ability to engage with their care team. And so if there is funding that's directed from CMS through those MCOs, there needs to be as much of a direct pass-through as possible. That's just my sense of my worry is that, if they take 20% of that funding off the top to support the MCO infrastructure, it's not getting down to the clinics where that care is much more effective when done by the care team with embedded case management for care coordination and complex care management.
Mike, thank you. Let me bring that forward with some of the colleagues that I work with on the managed care organization.
Yeah.
And I've heard this comment. Did you say you're with Confluence?
Yes, right. Yeah.
I think
even within our system, when we've tried to use case managers that are not closely tied to their primary care teams, their effectiveness drops down dramatically. And so we've learned from trial and error that you really have to have people that are close to home, who are in the same town or community, to be effective with those complex patients.
Okay.
And Mike, I may comment to one of Michael's earlier slides, especially around the partnership with MCOs and ACHs. I think that's why it's important to really have both involved in this work, because especially at a regional level or one provider or one CBO level, it can be really hard to work and cooperate with 5 MCOs. And so really we have that opportunity to help streamline that and manage better and really provide kind of a streamlined voice to the MCOs from all of our partners to put, you know, accountability and pressure each way on them as well.
Thank you,
Mike. Yeah, thanks, John.
Another
This is Molly.
Oh, go ahead, Molly. You first.
I was just going to say that I had a long chat in there just about spend down. I live in a rural elder senior population community, and we don't have Medicare Advantage programs here. We are dual eligible, and they're all stuck in a spend down. So they do not qualify for any Medicaid programs, and their health has suffered. And I have actually seen some tragic events happen because they did not have Medicaid coverage. I don't know if CMS has an idea of raising that income level of the Medicare, Medicaid patient to match just Apple Health, because at this time they don't match.
Yeah, Molly, one of the places that we skipped over quite quickly when I talked with ACHs was about long-term services and supports, and our colleagues over at DSHS are, I think, doing a very good job bringing forward two policies that I think that may help in the area that you're talking about. One is just having a system of presumptive eligibility, and we're trying that with the waiver today, and it's worked quite well over the last 5 years. And so they will be proposing to our federal partners at CMS that we do that across all of the long-term services and support system in Washington State. And at the Healthcare Authority and Department of Social and Health Services, we know we're asking for a big policy shift from our federal partners. So we do expect that one will be very difficult to negotiate, but there's all the reason in the world to do it. And the other one is some coordinated personal care that they have in mind is a more effective way to deliver the services. I apologize. I skip over that so quickly just so we can get into goal number 3, because that's usually where most of the ACH work is. But you know, with members of the board around the community, we find that all of these policies touch one of you in some way. So hopefully, and that won't solve all of the spend down issue, but at least those are policies that are going in the right direction.
Go ahead, Peter.
So Mike, as I look at the slides on in lieu of services and health related services, it looks to me like a lot of funding may go to places it's never been before and touching a lot of different agencies, community-based organizations, et cetera. Can you talk about how you envision the role of the ACHs in both, setting up the infrastructure, vetting the organizations involved, et cetera, versus direct contracting through the HCA? Where is the ACH in this milieu?
Yeah, Peter, you're asking the very next step that we need to dive into, and I really appreciate that. Let me just kind of mention a couple things, and then because that's a deep conversation that could go on for quite some time.
Right.
I agree with you 100% that we are going to be either asking organizations who have never been funded to do this, or organizations who are funded to do it now on a much smaller scale, and we're going to ask them to scale up quite large to do the level of services that we think the community needs. So what we've been talking with John and his colleagues about is developing an operational work group so that we can start talking about the roles and define roles, especially between the managed care organizations and the ACHs, and to also talk about what the responsibilities should be. So for example, just taking one small piece here, just the payment of the service. MC, one of the things I need to mention about in lieu of service is that it's optional for an MCO to offer them, and it's optional for a Medicaid client to receive them. But most of the time people do, because the services are valuable and they're highly cost effective. So that's why we want to see it done more often. But but obviously the MCO will have to make the payment. But there's a lot of work that an ACH could do to know about the perspectives and the priorities within the community, what is needed most often, and where to target populations. Also, just setting up the service, and being able to confirm that the service was carried out, and then possibly we may even have some form of payment to a community-based organization for carrying out this, for closing the loop and making sure the service is performed. But we have to work all that out as you're talking about, and that's why the capacity funding is being requested from CMS, and why we're also letting CMS know that don't expect us to be just hitting the ground running in January 2023. And then I think the other part to this is we want to make sure that we build out the hub, but we also want to work closely with the community-based organizations. And that's actually a lot of the comments that I get when I talk to any of the boards of the ACHs is, don't forget that you're going to have to work with the people who are actually performing these services. And you have to bring them along, because these are not organizations that work this way today. And you can't just build the hub with the ACH and it all just flips a switch and it all works. You're going to have to bring along this whole network of organizations that's used to receiving money in a different fashion, performing their work in a different fashion. And so again, we'll be making that point with CMS. We've already made that point with CMS when we talk to them monthly and try to give them a sense of where we're going with this application. So I admire the question, Peter. It's a very big question. If there's anything else that I can address about it, I'll give it a shot. But all of it is then the work that comes after we submit the application. We are not going to wait for the application to be approved. We want to start working out the operational roles as soon as we can.
Thank you.
Peter, I may jump in because we shared just some thoughts even with Michael prior to presenting, that the term community hub can mean a number of different things, and especially in our region, when we tried the Pathways Hub and decided to discontinue it, can really have some hesitancies come up on the sense that we would be going right down that direction. Really, again, I would reference what Michael said earlier. Really is the ACH role is helping to support that building infrastructure, community-based care coordination, that then health-related services can really insert itself into, and also ensuring that those things are well aligned. And so the goal ultimately would be to build that supporting infrastructure, that community-based care coordination organizations, the MCOs, and everyone can really work together in to deliver this appropriately. I will say every ACH is supportive of the intent and the concept. The nice thing about the waivers and the way that HCA has worked with each of us, we all can also ensure that that work fits with some of the unique components of our region as well. So make those small tweaks within those big concepts to align with the way we do it in our region.
Thanks.
And I just want to shout out, I know Caroline's been doing a good job working with CBCC partners and identifying some of those components and really getting an initial step in some of these discussions at our local area. And Caroline, I don't know if there's anything you want to comment above that.
I think in a nutshell, when we discuss this concept of a community hub, what we're gravitating towards is less of a centralized entity, the way things were envisioned under the Pathways Hub, and more thinking about an infrastructure that enables a connected system. So it's not one entity, it's an infrastructure that enables a system. Because we have a variety of partners across our region that are already connected a certain way, And it is so disruptive when you ask them to rewire all the connections. And so that's one of the things we're trying to figure out. How do we not completely rewire existing connections of partners doing this work? And also, how do we do this in a way that isn't just Medicaid specific? And the billing is something that, you know, I feel like there's a paradox when I see those the health related service bullets. We heard Ray say we need to find ways to sustain these services. I absolutely agree. But the paradox is that when we sustain it through billing of discrete services, we create this administrative burden that just slows, like just really burdens the system and sometimes sinks our partners, including small ones, like the ones that Peter called out, the ones that haven't been involved in this work. So that's the part that we're making sense of as a region. Like, what does this mean, and how do we need to structure this in a way that it doesn't harm our partner network? And there's still a lot to flesh out, but I guess those are some initial just thoughts for the board members to know that these are the discussions we've been having internally as we try to make sense of what we're seeing from the state conversation.
I appreciate the sensitivity about that. Obviously, a lot of work, a lot of thinking's been already done, so thank you.
Michael, I have a question about, you mentioned the CIE, the $1 million that were obtained and the thinking that's going into that. At what stage do we as ACHs get to provide input about the way that's shaping up? Because to be honest, it's a bit of a black box for me, but it's very relevant to this work. So any thoughts on that?
Just a couple, Caroline. First, want to thank Senator Warnick for being here and the legislature for funding us to look into this, and thank you so much. And we are happy to receive the money that we received, because what we're doing, Caroline, is we're taking the first steps that we would have taken even had we received the $15 million. So we're very pleased with the $1 million. A couple things that we're going through right now is let me just mention one very important part which will involve ACHs, and that's that part of the challenge that the Healthcare Authority has in requesting the money is that nobody yet has a very good look at what the investments have been to date in different kinds of community information exchange. And so one of the first things that was asked for in giving us the $1 million that we do some, I'll just call it a landscape review of what's going on in the state. There has been some investments that have been made that done differently in different counties to fit the needs of those counties. And so that's the first step that we're going to work with the vendor on, is just describing where we're starting from and what kind of investments have been made. And of course, we will need to work with each ACH to do that. The next step we want to take then is to do some kind of a assessment of what is the possibility of doing some kind of community information exchange strategy throughout the state. And we'd like to, again, work with a vendor on this so that we get an independent assessment of where we're at. Obviously, we see community information exchange as a need throughout the state, but we need some expertise inside the organization at Healthcare Authority and outside the organization to work together to come up with a true assessment of where we're at and what's possible for the next steps. Because as much as I would like a vendor to come back and say, here's a recommendation on how you can go forward, what I want is an independent, honest assessment of what's possible. Because it's sometimes hard to accept that advice from an independent vendor, but that's why we hire them. If they say, this is, you're not quite where you think you are, or it's a bigger step than you are envisioning to put something like this together. That's hard medicine to take sometimes when you want to do something, but it's a whole lot better than crashing and burning, say in 2025, investing a whole lot of money in something that you just kind of took as an idea. So we want to take a serious look at a landscape review and a very serious look at assessing what are the possible recommendations where we could go forward. And is it possible? What are the risks? So that's what we're trying to get to this year before the next legislative session starts.
And Michael, I believe we're a little over time, so I think we're going to wrap it up there. But I would actually encourage board members, if you have any other questions, to email myself and I can forward it on to Michael, or our team can work on responses. And Michael, I guess I'll leave you any final parting comments or thoughts before we move on.
Just to John, I hope we can hear from people during the public comment period that runs May 12th through June 13th. And finally, John, thank you so much for the invitation. It's the engagement is so valuable.
Yeah. And thank you again, Michael, for joining us. You explain it more eloquently than any of us could. So we really appreciate you taking the time to explain it and joining our board meeting. And
It's
Molly,
a pleasure working with you, John. Thank you so much.
thank you. I will turn it over to you, Molly.
All right, thank you. And at this time, it's Chris Kelleher with Strategic Planning and the Future State Update. So Chris.
Hi, everyone. I haven't spoken with you in a while. It's a joy to be back here again. I'm going to just do a series of quick updates about what has been happening with the strategy work group and the direction that we're heading in. If you give me a moment, I will do a screen share and show you. I know you've seen a lot of slides today, so I have only a few, I promise. All right. Can you all see that? Yes. Good. Okay. Wonderful. First thing to talk about is the as many of you know, the strategy work group was formed last year. Actually, it was formed at the very end of 2020, and we made a lot of wonderful progress over the course of 2021. For 2022, we have had some turnover in membership, and also thought that it was time to expand the membership and make it a bit broader. So we have 3 returning members who were part of the work group in 2021, and a number of new members. Rosalinda, Rosalinda and Molly are returning, as is Doug Wilson, who's a former board member. New members, Daniel Barbara, Mabel Bodell, Jesus, Peter, I guess I have you listed as Okanagan Chai. I guess I should list you as now, as of today, as a board member. Kelly Rimby, Nancy, and Dr. Tuggy. So we have now had 2 meetings of the new strategy work group, and bringing the new members up to speed, because there's a lot that we covered, as I mentioned, in 2021. So getting everybody to understand what's the journey that the strategy work group has been on, and where are we heading. When we talk about the journey that we have been on, the most important thing that we produced in 2021 were the 3 pillars. And so just as a reminder, many of you have seen these before, but they are, as pillars, they're our foundation. And so it's useful to keep coming back to them. So we have, there are 3 pillars. Build through an inclusive process of distributed leadership is the first one. And this was approved by the board last June, so a little bit over a year ago. Our pursuit of equitable system change will reflect the aspirations of the entire region, not just the concerns of certain groups or sectors. Second pillar, anchor in shared measurement. We will root our decisions in quantitative and qualitative data that depicts the health and well-being of residents. And then our third pillar, advanced transformation with a regional portfolio. We will use distributed leadership to develop a vision for equitable system change and implement it through a far-sighted regional portfolio. These three, the important thing to talk about with these three pillars is they're not sequential. So it's not like we do the first one, we get that all done, and then we move on to the second, and then eventually we move on to the third. The first two particularly are happening at the same time. They're happening concurrently. We have Sarah, who's now joined us, who will help a lot with moving forward that second pillar about shared measurement. Not doing as much with the third pillar about the regional portfolio. The idea is that the first two really help us eventually move on to developing a regional portfolio in a really effective way, because we're building the foundation in the first two that you see there. At the most recent strategy work group meeting, which was just last Thursday, we did an exercise, which I will show you, where we used a Jamboard, which is a way of interactively moving things around and brainstorming. And what we discussed was, for each of those pillars, what would it look like if we failed? And then what would it look like if we succeeded? And I'll just show you a quick image of what we did. You can see here, we were moving sticky notes all around. For each pillar, we asked the same question. If we're not successful with this pillar, what will we see in the region? Another way of thinking about that is, what is the business as usual that we're trying to disrupt, that if we fail, we will not disrupt and will still be there? And then the second question, if we're successful with this pillar, what will we see in the region? Another way of asking that is, what is the future that we're trying to bring into being? What are we going to see? What is the new future that we will see evidence of if we're successful with this pillar? So these are all the sticky notes for the second pillar, and then all the ones for the third. So we did this brainstorming exercise. This is something now that is a foundation for us, and then we're going to return to the next time that we get together. For what it's worth, the strategy work group meets once a month. I'll go back to the presentation. So you can see kind of what we're doing. As I said, we've now oriented everyone, and now we're moving on to thinking about next steps. The biggest next step that we have talked about is developing a regional compact. And I'm just going to talk very briefly about what that would be. This is just an introduction. When I introduce this concept, I think this is something that we're hoping to talk with the board a lot about in the coming months, and it's something that the strategy work group will be devoting a lot of effort to. So I'm just going to introduce the concept of a regional compact. And again, we will come back to it in the future. So what is a regional compact? It is a mutual agreement between partners that ties them together and formally states their shared purpose. Sometimes these are also called charters. They're called partner agreements. It's the same basic idea in all these things. The idea is you establish an actual agreement among the partners in your network where people literally sign something and they attest to what they're committed to in being in this endeavor. So what does the compact do? It describes the mission of the network, and it explains what the vision for the region is that everyone's coming together for. Why are we coming together? It's because we have this mission. We have this vision. It presents the network's values and its operating principles, meaning that it explains how we aim to achieve change. What is our method that we aim to follow to achieve change? And it defines what it means to be a network member. So it says, this is what is expected of the members, everybody who has signed the compact. And this is what members can expect from the network and from each other. So one of the things that we'll be doing in the strategy work group over the next couple months is talking about exactly what form we want this to take. There are a lot of decisions to make about what exactly do you put in here? You know, what exactly does it contain? In some way or another, it will address the three pillars. Because that is our foundation. But then what are the other things that will accomplish what I've just laid out here? So just to give you a couple examples, these are not long. Generally, you when you do this, you try to keep them brief. Here is an example from Archie. Archie is the Atlanta Regional Collaborative for Health Improvement. They call theirs a partner agreement. You can see it's 2 pages long. It lays out the vision. I know this is very fine print here, but this gives you a sense of what the sort of generally how something like this looks. They have a preface that explains what they're all about. Their vision, their mission, their priorities are laid out in a very succinct way. They talk about what their purpose is. They talk about partner commitments. And then people sign it. In their case, they started off when they launched in they had a launch over a period of a couple of years between 2011 and 2013, started off with 30, and they gradually added more, and to the point where they're now up to over 70. So gradually over time, the network has grown, and more organizations have signed their partner agreement. And one of the values of this is that there's no ambiguity. If you're a member of the network, there's no ambiguity about what you've signed on to. You've all signed the same agreement. Another example are our friends in North Sound ACH. They have what they call a compact, a collaborative for what they call their collaborative action network. There's also, as you can see, it's very short. There's actually a third page that people sign, but this is basically what you see here is basically what's there. Again, I know it's very small, and we can send you the links for the actual full agreements, but just to give you a sense of roughly what's here, a few basic points about what it is we're all in this for. So they're in the process of doing this right now. This is something that they've been working on for a few months, and that they're rolling out now. Final things. Okay, as I promised, not very many slides. I'm going to show you one more. Because I want to make it clear what a regional compact doesn't do. It does not legally obligate partners to do anything. So it is not. You're signing on to. You're saying what you're committing yourself to as a member of the network, but you're not legally committing your organization to anything. And doesn't eliminate the authority of the leadership structure, the board in this case, or whatever other leadership structure an organization has, to make its own decisions and to follow the path that it thinks is best. And it doesn't get into strategies and tactics. Again, as I showed you, these are brief documents. Partly with the idea that what you want to do is to form, the whole point is to form a network that then makes decisions. And so you don't want to lay out all those decisions ahead of time, because that's why you're forming the network, is to be able to do this, to develop like that regional portfolio that I talked about. So as your strategies and your tactics need to evolve as your experience grows and as realities shift, and you don't want to be rewriting your compact every year. It needs to be a durable document that can hold for many years. That's it. I will stop there. And no more slides, as I promised. And ask for discussion or questions. Before I do that, just one other thing to peg is that we are hoping that in the July retreat that NCACH has planned, that we'll be able to talk about this. We'll really be able to dig into this deeply with all of you. That's sort of the overall arc that we're planning to be able to go into some detail about this when we get together for the retreat in July. That's it. Let me know. Are there any questions, comments, strategy workgroup members? We have several on here. Anything that you please feel free to jump in and explain where I'm wrong or anything. Don't hesitate.
Well, I'm going to take on the homework of looking at each of the other compacts or agreements in place with the other organizations, just to see what they do and do not do. So yeah, can and cannot do. Learning more. Anyone else?
I may just comment, like, when you think about when we originally started as an ACH, right, we kind of took on the mission of the MTP, and then we organized ourselves based on this Medicaid transformation toolkit. And then when we got, basically halfway through and we were looking at what we were above and beyond that, that's when we really, updated our mission to focus on whole person health and health equity, and really be the pillars is really how we're organizing ourselves around how to achieve that mission and vision moving forward, and really how our partners are going to come to the table to do it too. So in a way, we were moving from a space where some of that was just created for us to where we're really creating that, and that's where that next step is. And what really excites me is really that aspect of it being really distributed and having the partners be able to come to the table and take ownership and buy into how we work together versus necessarily just coming into a state-created transformation project.
All right, thank you. Thank you, John. Thank you, Chris.
Oh,
And we're getting close.
Molly, I just realized there's one more thing I wanted to mention. Is that okay? Yeah, just quickly. We, as many of you know, we have partner convenings every month. We've been having them for several months, and I want to invite you all to attend the partner convening. I'm going to put a registration link in here. It's May 17th from 10 to 12. If you're free, if you're able to attend, it's great. We're bringing together different partners from around the region and hoping to grow actually over time to bring in more and more partners. And you can see, you can follow that. And we have a, well, if you're able to attend, please do. Thank you. Thanks for your time. I appreciate it.
Great. Thank you, Chris. All right. So yeah, that is May 17th. I also had a couple of announcements. June 6th is our next board meeting, executive board meeting. And then we're also planning, I think you all have heard, a retirement party for Linda Evans-Parlett. June 10th is the date that we have landed on, between 3 and 6. More information to follow. I'm not sure if someone else from the staff was going to be mentioning it, but I did want to at least get that out there so that people can put it on their calendars, begin moving, shuffling things around. June 10th, 3 to 6. And at this time, I open up to anyone who has anything that they would like to add, any public comment at this time. If you want to go ahead and speak up. Any other announcements from anyone?
I may just confirm, Teresa, I know you're on here somewhere. That will be at our office, correct, Teresa? Or is it going to be another location?
It'll be our office. Sorry, can you hear me? I'm at a different desk.
Perfect. So it'll be at our office in East Wenatchee. So just make sure if you are traveling and coming to also allocate travel time.
Yeah, we're doing a combined open house so people can see the new office and that always very delayed due to COVID.
And Teresa, you were a little hard to hear on my end. I think you said it's really an open house and retirement party, and it was delayed because of COVID. And so even though we are about 6 months late celebrating Linda's retirement, we are going to celebrate Linda's retirement.
Probably takes about 6 months to get used to being retired, so I could imagine. All right, any other comments, notices, announcements?
I do want to say thanks for the meeting. And then I do have an announcement that I'm just going to throw out there is I'm working on, well, I do have a commitment already. If you guys know the Nick of Time Foundation, this will be their first visit in our region. I've got them committed to come do primary intervention to children with congenital heart disease or heart disease period. Before they, suddenly collapse in cardiac arrest. This is a screening of cardiac for children. And the Nick of Time Foundation comes with their own cardiologists and their own diagnostics. And this is the first time they're coming to the region. And I've got them committed in May, the first Friday of May in 2023. And the reason I'm saying this is that I would like to try to partner with as many school districts as possible in Chelan, Douglas, and Okanagan counties to make it the largest heart screening of children in our state. And so I was wondering if you're interested in helping me do this primary intervention, I'll just give you an example. I went and I had a volunteer in Seattle before they'll commit to come over here to help me host the event. And I did 2 schools in Seattle, and we screened almost 400 children, and they caught 4 congenital heart defects on these 4 children. That could have been life-threatening. And they caught it before, they collapsed on a basketball court or on a soccer field. And one of them was a pretty serious one. And so that was a lot. I want to say catching 4 out of 400 is a lot. And they're seeing more post-COVID. So here we are, the sequelae of COVID on hearts might be more significant than we thought. So anyway, I'll get off my soapbox there. So,
Thank you. Thank you.
Ray, could you please repeat the date?
it'll be in May. Let me pull it up. It'll be May of 2023.
Okay.
And May 20, I think it was May 5th, if I remember right.
Okay, so 1 year from now.
Yes.
Okay.
So we have some time to plan.
Okay, great. I love that. Happy to help.
Luxury, huh? Yeah. Sounds great. All right. Anything else for the good of the group? Hearing none, I will go ahead and adjourn at 3:26 by my calendar. All righty. Everyone have